It can give you indicators of contact, and the lesion markers seem to be very precise. So it's a very different experience.
Yeah, I mean, I think, currently with the two commercial systems that we have available, I completely agree with both of you. I use intracardiac echo to assess contact, and I use mapping to look for lesion overlap and make sure that I've given enough overlapping lesions.
Welcome to Rhythm Interventions Unplugged, your monthly deep dive into the world of electrophysiology. Join us as we explore the latest research, share clinical insights, and provide practical tips to keep you at the forefront of your field. Now here's your host, the Director of Cardiac Electrophysiology at St. Bernards Medical Center, Dr. Devi Nair.
Hello, and welcome to today's podcast titled Mapping During Pulse Field Ablation, Essential or Overrated? I'm your host, Dr. Devi Nair, Director of EP at St. Bernards Medical Center in Jonesboro, Arkansas. And today we have the honor of diving deep into a crucial debate in the field of cardiac electrophysiology with two distinguished experts, Dr. Bradley Knight and Dr. Andrea Natale. As the landscape of atrial fibrillation treatment evolves, so too do the technologies and methodologies we employ. Pulse field ablation holds the promise of ushering a new era in the treatment of atrial fibrillation, promising selective tissue ablation with minimal collateral damage. However, the role of mapping during this procedure has been a subject of much discussion. Is it indispensable for ensuring successful outcomes, or does it simply add unnecessary complexity to a procedure designed for precision and simplicity? Joining us to unpack these questions is Dr. Bradley Knight, a leading authority in electrophysiology known for his innovative approaches and extensive research in this field. Alongside him is Dr. Andrea Natale, a world-renowned electrophysiologist whose contributions to the development and refinement of ablation techniques have been pivotal in advancing our understanding of AF treatment. There have been multiple recent studies that have been published that delves into the significance of high-density mapping during PFA procedures. One set of studies suggests while PFA offers inherent precision, the integration of mapping can significantly enhance accuracy. On the other hand, we have other studies that compare procedural characteristics and outcomes, indicating that the added complexity is not needed. Given this context, Dr. Knight, I'd like to start with you. Can you start by explaining what mapping during pulse field ablation entails, and how does mapping during PFA differ from mapping during other types of ablation procedures?
Sure. Good morning. I will tell you just our current practice. We have both Navix and Cardo, and probably half of us use each. I use Cardo. We have the Medtronic Pulse Select PFA system, and we also have Farapulse. So my approach has currently and still been placing a high-density mapping catheter, usually a pentaray, to get a pre-ablation left atrial map, and then after ablation to do another map again with the high-density map.
Thank you, Dr. Knight. Dr. Natale, you've been on the forefront of advancing ablation techniques for a very long time. And so based on your extensive experience, how do you perceive the necessity of mapping in PFA? Especially this, what do you think are the impact from a long-term outcome standpoint?
Well, obviously right now, we don't have any FDA-approved PFA system that has a integration with mapping system. So we're using other mapping system, as Dr. Knight mentioned. I primarily use the same mapping system that Bradley mentioned, with the idea of checking for sort of effect of what I'm trying to do. The device that we use for PFA do not have the sort of high definition of the recording that we are used to when we do mapping in the cardiac chamber. And so I use really the mapping system to confirm that I have done enough, that I reached the end point that I'm trying to reach in the specific patient. And that's really the goal right now. But obviously, as the system evolves and there is integration that is designed for that specific system, I think things are going to change, and the benefit are going to go beyond. I'm sure we're going to talk about in the next few minutes about the potential advantage of a fully integrated three-dimensional mapping system with a PFA ablation device.
Thanks, Dr. Natale. Dr. Knight, why do you think this is even a debate? I mean, for years, we as the electrophysiologists always use mapping in the lab. So why is this even a topic of debate among, clinicians and researchers?
Well, I think it's a topic of debate because we have a new tool now, and we always, whenever we get a new tool, try to think of ways that we can take advantage of it. When we started using the cryo balloon, I think that the ability to determine pulmonary vein isolation without a mapping system was pretty useful. We would do a pre-map, but after we would isolate the veins based on the pulmonary vein potentials, I wouldn't go back and do another map. So I think the advantages of a three-dimensional mapping system for PFA currently are your ability to see what you've done. As Dr. Natale mentioned, you go back and I can send you some examples of times when it matched perfectly with what we thought we did, times when we didn't get certain areas like the roof well, and we would go back and re-ablate. And then times where I was surprised at how extensive the ablation was when the goal on that particular patient was just to isolate the veins, and maybe because they had a common antrum, we went very antrally, but the post-map showed that we had ablated the whole posterior wall. The other two advantages are minimization of fluoroscopy. I don't practice zero fluoro, but that's a driver, I think, for the use of mapping systems right now. And then, the other advantage of having it would be kind of this integration and being able to see the position of your catheter and look for contact.
Thanks, Dr. Knight. Dr. Natale, returning to you. Another critical point or crucial point raised in most publications is that there is a potential of mapping to reduce the recurrence of arrhythmias, especially coming back to Dr. Knight's point about how extensive that ablation could be. How do you see this balancing out against increasing procedural time and complexity? Are there specific patient profiles where the benefits of mapping clearly outweigh these downsides?
And clearly, I think the non-paroxysmal is a group where I absolutely feel that it's important to have more information. If in a typical paroxysmal, young patient with no structural disease, I think where you're clearly planning to do just a pulmonary vein, probably the mapping system right now provides only an extra check on the efficacy, which for the most part very rarely shows some sort of need for additional ablation. So if I had to, be selective in the sort of big scheme of saving money, probably I would use the mapping system for sure in non-paroxysmal and maybe be more sort of relaxed with a typical paroxysmal patient.
Okay. Thanks, Andrea. Brad, there's quite a bit of current evidence from Europe that really does not highlight the all these advantages that both of you are talking about when using mapping. What do you think are the challenges or concerns that you have about some of the data that's already published that is not showing these advantages?
Well, I think it's always hard to show advantages and outcomes, but I think if you just look at the procedural experiences that you have, it's going to dictate what you do. And I agree with Andrea. In fact, I would take it another step that for the paroxysmal patients, I've recently moved to not even using a coronary sinus catheter. So a very minimalistic approach for PAF in patients who show up in sinus rhythm. But I think we've all now seen patients who have, during the persistent AF ablation, when you do an extensive ablation with PFA, I've already had patients convert to mitral flutter and then ablated their mitral flutter with the PFA. Patients convert to typical flutter. So the advantage of the mapping system is how to manage those. Honestly, I didn't do a whole map of the mitral flutter because it was pretty obvious what it was, and we did pacing maneuvers from the ablation catheter. But having a CS catheter and a mapping system is useful in those patients when they convert to left atrial flutters.
Thanks, Brad. And Andrea, do you want to add anything on the clinical evidence that's already been published? Like, what are your outcomes of PFA procedures with mapping compared to those without mapping that's been published?
No, as Brad said, it's very difficult to show. Also, you have to look at the type of patient. Most of the paper really includes those paroxysmal patients where the benefit is minimal. or early persistent, which are almost the same group. But I agree. Actually, our approach is exactly the same what Bradley mentioned. For a paroxysmal coming sinus rhythm, we don't put, we use a duodecapolar, not just a ACS carry. We don't put any, we just do the ablation. Instead, in the persistent, we always have the duodecapolar, which quickly tell us when the patient organizes what kind of flutter we're dealing with. So we can kind of take care of it. So I think you have to sort of realize that, it's very hard to show a benefit, a clinical benefit. First of all, in a small number of patients, which is most of the study it includes so far, that are for the most part typical paroxysmal or early persistence, where the chance that you're going to find something unusual is much, much less common. So it's hard to, and also we have to realize that none of the mapping systems now are integrated with the ablation tool. So it's not the perfect sort of type of combination. So we have to consider all those factors when we look at the data that are coming out now.
Ready to elevate your skills in electrophysiology and cardiac rhythm management? Don't miss Rhythm Interventions Online 2024. Engage with top experts, discover the latest advancements, and network with peers from around the globe. Rio is hosted by Dr. Devi Nair, course director and host of the Rhythm Interventions Unplugged podcast. This is your chance to ask questions, gain new insights, and deepen your expertise. Our world-class faculty will be live from November 20th to 23rd. Register now for free at riocongress.com.
It's a great segue, Brad. A question for you. Is there any recent technological advancements that you feel has improved your accuracy and efficiency in visualizing these PFA catheters with the mapping systems that you're using? I understand you use both Cardo and Insight systems, and you have both commercially available pulse field ablation catheters as well. So any new technologies that you're using that has made you want to use the mapping as well?
Maybe not new technologies, but these companies are trying to come up with advantages to use their system. So I know that the NAVX system has some software features that really do enhance the ability to localize the catheter and see where it is and catalog your lesion sets. But I think, as Andrea mentioned, these are still third party. They're not the same company as the PFA manufacturer, not truly integrated. You can have a perfect map, and after a couple deliveries of PFA, sometimes you'll see shifts in the map without the patient moving. So suddenly you've spent all that time getting a nice map, and really it doesn't offer you that much of an advantage. It is kind of an interesting thing where that drift that occurs sometimes kind of settles back to a correct location. So yeah, I think Abbott and Biosense are trying to come up with ways to show advantages of their system when using other companies' PFA tools, just like with the cryoballoon. But I don't think they'll ever be as integrated as when the other companies come up with their own mapping systems.
Yeah. Andrea, you kind of mentioned about the current systems not being integrated. Would you like to discuss what the future looks like when it comes to integrated mapping, and what is it that you're looking forward to when you talk about mapping in PFA for the future?
We already have used a fully integrated system with the Johnson & Johnson Varipulse in the Meyer study that was an FDA ID that has been presented. I think is coming out in circulation and should hopefully lead to approval soon. We also have used the Affera system with Medtronic that has a fully integrated large footprint catheter with the mapping system. So we already experienced the benefit of a fully integrated system where you have the ability to look at the lesion deployment and kind of identify area where you might have to do a little more to have a higher chance of permanent effect, and also system that allow you to map another arrhythmia if that occurred during the procedure. So clearly that is coming. The same is true for Boston, that has a three-dimensional mapping system that has been developed, integrated with the FARWAVE, and should become available to us within the end of this year or early next year. So I think, but we already have experienced the benefit of a fully integrated mapping system in some of the FDA that has been done. So clearly, we're looking forward to that, because that would be clearly a optimal setup, even to assess, Bradley mentioned before, to assess contact. Right now, we rely exclusively on intracardiac echo, which is not available that much outside US, and has been valuable in sort of maximizing permanent efficacy, I would say. But I think the mapping system will help a lot with that, and also will help a lot people that are really used to do floorless. I think a fully integrated system will help a floorless procedure. I'm too old to go in that direction. I try to use less fluoro, but so that I think I'm looking forward to that. But right now, the only things we have is eyes, which is certainly a good tool, but it's not sort of all of it, all of what we need.
If I can add to that, we have experience. Sorry to interrupt, but to add to that, I would agree. We have experience now with the Volt system, which is integrated with Abbott's NAVX mapping system, and it can give you indicators of contact, and the lesion markers seem to be very precise. So it's a very different experience.
Yeah, I mean, I think, currently with the two commercial systems that we have available, I completely agree with both of you. I use intracardiac echo to assess contact, and I use mapping to look for lesion overlap and make sure that that I've given enough overlapping lesions. Even though we're in a completely new era of ablation with pulse field, one of the biggest challenges that I've faced is the loss of EGMs with the first application of the energy, and you really are dependent on some type of imaging tool to make sure you have enough overlap. So definitely being an integral part in my ablation days. So just as a final thought, Dr. Knight, what advice would you like to give our audience and our electrophysiologists that are considering the use of mapping during PFA procedures in their practice? Because it's a new world out there now.
Well, I don't know if it's advice, but I think it makes sense to continue to use the mapping system that you're currently most comfortable with. I think that there's value to the mapping system, just like programmers on pacemakers and defibrillators. What you're most familiar with is probably the tool you should be using. I had hoped that when PFA came out, we could take advantage of it and eliminate the mapping part of it, because it does take time before and after. It requires an exchange. You have that thing still sitting on the table. So far, I think I would advise people with your early experience to continue to map after you ablate to kind of learn what you've done.
Dr. Natale, what would you advise so that people can maintain their high success rates across the board?
I think I totally agree with Dr. Knight that the value of the mapping system is to confirm the endpoint, which it's hard to get with the current devices. And, obviously, I mentioned before eyes. I feel that eyes right now is a big component of that process because it helps to sort of confirm that you're in contact. Fluoro, we have several examples of fluoro not being the ultimate way to assess contact, and we usually try to push a little more when you look at eyes. So, but the combination on eyes and mapping, I think, is valuable to sort of maximize the chance that the patient is going to come to the lab only once, especially for the paroxysmal patient.
So, as we've heard from our esteemed panelists, the role of mapping in pulse field ablation is a nuanced topic with compelling arguments on both sides. I think the studies and insights shared today highlight the ongoing debate, but the idea is that, the question is whether its use is justified, might ultimately depend on the specific clinical scenario, like both our guests highlighted, the patient profile, and also as these technologies evolve in the field. Thank you, Dr. Knight and Dr. Natale, for sharing your invaluable insights with us today. And thank you to our listeners for tuning in to this thought-provoking discussion. Stay connected with us for more episodes as we continue to explore the latest advancements and debates in electrophysiology. Thank you.
Thank you.
Thank you, Dave.
That's all for this episode of Rhythm Interventions Unplugged. Never miss a beat. Make sure you subscribe to the podcast and please share your thoughts with a review. We'll be back next month with another episode. Until then, keep the rhythm going.